Hello, my name is Lisa Zicker, and I am a rheumatologist and clinician educator at Washington University in St. Louis School of Medicine. On behalf of the American College of Rheumatology Working Group for the virtual Practicum in Adult Rheumatology, we welcome you to the 2022 series. We are thrilled to be able to offer a schedule jam-packed with excellent clinicians, educators, and thought leaders at the forefront of our field. We hope that this series of lectures introduces incoming fellows to the fundamentals of adult rheumatology practice and perhaps reinforces basic concepts for those who are participating and beyond their first year of fellowship study. In order to improve our programming for future years, we will invite you to provide feedback in the form of 2 polling questions at the end of each lecture, as well as a survey that will be emailed to you at the conclusion of the 2022 VIP series. Thank you so much for your participation, and we hope that you enjoy the schedule and lineup of the 2022 Virtual Practicum for Adult Rheumatology.
Wonderful. Thanks so much to Dr. Zicker for that introduction. I'm going to start us off by introducing our first speaker. My name is Nathan Karp, and I'm a second-year clinical fellow at the University of California, San Francisco. It's my privilege to introduce our first speaker, Dr. Mimi Margaretten, who will be speaking about approach to the patient with rheumatic conditions. Dr. Margaretten is a clinician educator and professor of medicine at the University of California, San Francisco. She's the clinical director of rheumatology at Zuckerberg San Francisco General Hospital, where she teaches medical students, residents, and fellows in the rheumatology outpatient clinic, as well as the inpatient consult service. Her academic interests include improving clinical reasoning skills to enhance physician problem solving and improving outcomes for vulnerable populations. And she's one of my mentors in our fellowship program. So I would like to turn things over to her as she pulls up her slides, and please feel free to write questions in the Q&A, and I'll moderate those and we'll address them after her presentation.
Great, thank you so much, Nathan. And I just want to check and make sure you can see my slides appropriately. Okay, great. Well, I also want to echo Lisa and Nathan and just give you the warmest welcome. We are so excited for you to be starting your rheumatology fellowship. And this is really a broad introduction, and I know it's the first lecture, the approach to the patient with rheumatic disease. And I'm just gonna see if I can advance my slides. Great. So many of you will have heard these themes and concepts if you rotated through rheumatology as a medical student or during your residency. And again, this is an introduction, and hopefully some of these points will be familiar to you. I have no disclosures, and I'm going to start with our learning objectives, which for this morning to help you identify key elements from the H&P to localize musculoskeletal symptoms, to differentiate between inflammatory and non-inflammatory arthritis. And then we really want you to be able to implement a systematic approach to diagnose different patterns of inflammatory arthritis. And finally, to be able to use data from your H&P to inform a hypothesis-driven selection of subsequent labs and studies. So first, identifying the key elements from your history to localize musculoskeletal complaints, really going back to medical school. And when you're taking your history, you know, we all have certain mnemonics. I always use that OPQRST when asking about pain or swelling, to think about the onset, to think about the quality, is there radiation, is the time course. And with that time course, it's really important to note, is it acute, subacute, or chronic? And to ask these questions that are very specific to rheumatologists, you know, what makes it better? What makes it worse? Is there morning stiffness? And certainly you want to also be able to include a question about function. Is the patient able to do their usual activities, to do their chores, to perform their job, to you know, do activities around the house? You also want to make sure and to inquire about systemic symptoms, fevers, weight loss, chills. And then when considering any rheumatic disease, it's really important, of course, as with every patient, to take a really detailed medication history. So you're going to ask about not only what are they taking and any complementary or alternative medications, but to specifically ask about NSAIDs or a statin, is the patient on a sulfa drug or a checkpoint inhibitor. Moving through the history, you also want to make sure to hit upon the rheumatology review of systems, which is a bit different than your general review of systems. And to review that, when identifying these key elements from the history, you really want to take a systematic approach, and again, just go from head to foot. So when you're doing your review of systems and starting with the head, you're going to ask about alopecia, scalp pain, hearing loss, a red painful eye. Do you have dry eyes or dry mouth? You're going to ask about oral ulcers, poor dentition, jaw claudication or fatigue when chewing. You're going to ask about the lymph system. So do you have any enlarged nodes or lumps? When asking about the cardiac review of systems and chest pain, you're going to ask, is it positional? For the pulmonary review of systems, you're going to ask, do you have shortness of breath, a cough? Do you have pleuritic chest pain? Is there pain when you take a deep breath in? With the abdominal review of systems, you're going to ask about constipation, diarrhea, postprandial pain. For the skin, you want to know, do you have any rashes, dry skin, tight skin, nodules, or Raynaud's? You may have hit the musculoskeletal system in your HPI, but again, thinking about joint swelling, morning stiffness, back pain. When you're taking a GU or GYN history, you're going to ask about testicular pain and a pregnancy history. You may not always do this in a general review of systems, but with rheumatology, you want to ask about a hematologic review of systems. So is there a history of clots, such as DVTs, pulmonary embolisms, or stroke? You're going to ask about any history of low white blood counts or anemia or low platelets or bleeding problems. For the neurological review of systems, you'll ask about sensory changes, foot drop, weakness, and then again, if you haven't already, certainly systemic symptoms such as fevers or weight loss. And this is just an example of a rheumatology review of system that's not the exhaustive list you might use. So once you've done with your history, you're going to move on to the physical exam to localize any musculoskeletal complaints. And that starts with inspection. So again, going back to medical school and thinking about just looking at the patient. And you're going to inspect and see if there's any swelling or color changes in any of the joints. Are there any deformities? Is there ulnar deviation or swan neck or perhaps Boutonniere's deformities? You're going to look for muscle wasting or atrophy. When you actually are palpating, you're feeling for any tenderness with palpation. You're feeling for any synovitis in the joints, as well as any temperature differences and perhaps crepitus. You're also going to want to do a range of motion on each joint to make sure that a patient has full, or if not, what is their limited range of motion. And then again, just to have a very consistent routine and a systematic approach. So when I examine a patient and for their musculoskeletal exam, I start at the hands, I move up to the wrists, elbows, shoulders, then I examine the neck, hips, knees, ankles and feet, and then I do the back or neuromuscular exam. And this is just my approach, so you may have a different order, but the most important thing again is to have the same order each time. So when you're identifying the key elements from the physical exam with musculoskeletal complaints, you need to be able to differentiate, is this an arthritis, a bursitis, or an enthesitis? So a couple representative drawings. Here we have a patient, or actually a drawing of the anatomy of the knee. And you can see here is where the joint is. Here we have a prepatellar bursa. And there's a couple different points where the tendons insert to bones. And so the entheses are here. And if you move over to this drawing, you'll see a normal joint. Here where it's red, that is synovitis. So in the example here, they're giving RA, but it's inflammation within the joint space, as opposed to in this picture, enthesitis, where you see inflammation where the tendon inserts into bone. And some typical places you would check for this would be the Achilles, where the Achilles tendon inserts into the calcaneus, here in the elbow, and you can even have some spinal enthesitis. And if we move to the next slide, here are a couple patients with just representative pictures where you see a large knee effusion as opposed to a patient having bursitis here in the prepatella area, prepatella bursitis. And then below we have an MRI. It's a fat suppressed image where inflammation is bright. And here you can see the patella tendon inserting into the patella and it's bright. So this is enthesitis. Now, when you're a rheumatologist, a lot of rheumatology is considering rheumatic disease and keeping a broad differential. You're going to have patients who are referred to you with very common non-inflammatory conditions. On physical exam, you'll need to differentiate, is this arthritis or is this something else? And so here's just a sort of list of some really common non-inflammatory hand problems that you will see and need to really differentiate between an inflammatory arthritis, a systemic illness, versus perhaps more of a non-inflammatory musculoskeletal complaint. So here we have an example of carpal tunnel syndrome. And so on exam, you'd be able to perform a Phelan or Tunnell's test and perhaps diagnose it this way. The second very common referral you might see for non-inflammatory arthritis would be trigger finger. And there a patient is going to be describing a locking and painful popping with flexion or extension. You may perhaps see someone referred for wrist pain and it ends up being de Quervain's tenosynovitis. A helpful physical exam maneuver would be a Finkelstein's test to help rule in or rule out de Quervain's tenosynovitis. And then you will see a lot of thumb CMC osteoarthritis. I think that takes us to our first poll question. So, a 78-year-old man with a history of insulin-dependent diabetes, osteoarthritis, and gout presents to your clinic reporting a painful swollen knee for 1 week after a mechanical fall at home. On exam, his left knee is warm, tender to palpation, and he has a moderate effusion. There is no tenderness or to palpation or synovitis in any other joints. So the next best step is to A, obtain a bilateral weight-bearing x-rays, B, obtain a uric acid, C, perform an arthrocentesis, or D, obtain a CBC with diff and blood cultures. And I'm just going to give you a few moments to vote. And great, okay, so I see most of you have chosen perform the arthrocentesis. There were a few who opted for obtaining bilateral weight-bearing x-rays, and the answer is, just trying to advance my slide here, C, perform the arthrocentesis. So great, many of you got that. And again, sort of the next best step. You might actually do all these things, but if you want to be able to determine if this is an inflammatory or non-inflammatory arthritis, then x-rays won't tell you that. You know, you may obtain a uric acid, but it's not going to let you know if the patient has an acute gout episode. And a CBC with diff and blood cultures isn't going to tell you if that joint is infected. So that brings us to differentiating between inflammatory and non-inflammatory arthritis. So the most helpful things for this would be to obtain a very careful history and perform an arthrocentesis. Now, physical exam is very helpful in identifying painful swollen joints, but the underlying pathology may be difficult to tell from physical exam alone. And sometimes you'll hear, you know, when you're seeing a patient, another provider might say, oh, well, the patient can range their hip or knee, so we know it's not an inflammatory infected joint. And that's really not the case. You know, really arthrocentesis is gold standard to determine if the patient has inflammatory or non-inflammatory arthritis, and often the history will give you a good sense of that as well. Now, the SID rate and the CRP, they can be, helpful if it's elevated, but essentially they're extremely non-specific and can be elevated in many different conditions. So thinking about the history and how can the history be helpful? Well, there is actually some great examples, some studies that show you epidemiology and history alone can help your pretest probability and help guide, which blood tests or imaging you might order. So for example, in axial spondyloarthritis, these questions you can ask on history alone really can increase your odds ratio of diagnosing axial spondylitis. So for example, if a patient answers, really does report an insidious onset, that improves your odds ratios by 12. If the patient says, yes, I have to get up at night and walk around for my back pain to improve, that gives you an odds ratio of 20. And then you can see these other features on history and epidemiology. So a young age of onset, if it improves with exercise, or if there's no improvement with rest, can really, really increase your pretest probability. Again, arthrocentesis is the gold standard. So with that, we'll come to our second poll question. Here we have a 78-year-old man, very similar to the last case, with a history of insulin-dependent diabetes, osteoarthritis, and gout, presents to your clinic again with that 1 week of a swollen knee after a mechanical fall, and you do decide to perform the arthrocentesis of his left knee. However, you only get enough fluid to send to the lab for one test. So you choose A, gram stain and culture, B, the synovial white blood cell count, C, synovial white blood cell count with differential, or D, crystal identification. Okay, there's a little bit of spread. Many of you picked gram stain with culture. Some of you picked synovial white blood cell count with differential, and some of you picked crystal identification. So great, and let me see. Sometimes it takes a moment for me to be able to move my slide forward. Here we go, great. So the answer is gram stain and culture. Now, clearly, if you have enough fluid, you're going to send for the gram stain and culture and the synovial white count with differential and with crystal identification. But you're most concerned about septic arthritis, a bacterial septic arthritis. And so if you only have a little bit of fluid, you're going to choose the gold standard test, the gram stain and culture, to help either rule in or rule out the most worrisome thing on your differential septic arthritis. Synovial white blood cell with differential is important in that it can help you while you're waiting for your gram stain and culture to really decide if the patient needs IV antibiotics while waiting for the gram stain and culture, but it's not going to actually tell you if the patient has an infection. And again, crystal identification is important, but a patient may have co-infection where they have both crystals and infection in a joint. So let's just talk a moment about arthrocentesis. There's really considered 4 categories of fluid in joints, and the arthrocentesis can help differentiate between non-inflammatory and inflammatory arthritis. So non-inflammatory synovial fluid is considered when the white blood cell count, the synovium, is less than 2,000. And this would include categories of disease such as OA, post-traumatic disease, chondromalacia patella, osteonecrosis, hypothyroidism, and Charcot arthropathy. If the synovial white blood cell count is greater than 2,000, then it's considered inflammatory, but there can be a variety of causes. So it might be RA, lupus, a spondyloarthritis, crystal disease, vasculitis, or infection. And then when you get to very high white counts, greater than 100,000, that's considered septic or pseudoseptic joint. Most often, by far, it's a non-gonococcal bacterial infection. However, crystal disease such as CPPD or gout on occasion can cause extremely high white counts in the synovial white blood cell. And then the fourth category is hemorrhagic. And this is when the fluid is red, opaque, does not clot ex vivo, and some causes might be trauma, tuberculosis, pigmented villonodular synovitis, neoplasia, or coagulopathies. And just one more point about the synovial white blood cell counts and differentiating between inflammatory and non-inflammatory arthritis. There's been a meta-analysis specifically looking at septic arthritis and to see if there's any symptoms or signs on exam or in the history that can help differentiate between infection or crystal disease. And the truth is, it's not that helpful. So you can identify, patients who have septic arthritis will have joint pain, there'll be some swelling, but systemic disease symptoms such as fever, sweats, or rigors are really not sensitive in determining if the patient has an infection in that joint versus another cause. And it's certainly not, specificities can't even be calculated. It's extremely non-specific, and the studies were done in patients who they all had septic arthritis. And below you can see these very high likelihood ratios in terms of a synovial white blood cell count greater than 100,000 has a likelihood ratio, positive likelihood ratio of 28, which decreases as the white blood cell, synovial white blood cell goes down. However, just remember, it's gram stain and culture that are the gold standard for diagnosing septic arthritis. So all this data was derived from comparing to the gold standard, which was not synovial white blood cell count, but gram stain and culture. Okay, so next goal is to really help you develop a systematic approach to diagnosing inflammatory arthritis. And the way we do this is we consider the number of joints involved and the distribution of joints. What are the joint size? Is it symmetric or asymmetric, axial versus peripheral? So this is not a poll question, but I really want you to think about this case. So a 21-year-old woman with a history of thyroid disease is referred to your clinic for joint pain times 4 months. She reports hand and wrist pain and swelling that improves after she takes a hot shower in the morning. She also reports occasional flaky rash on her elbows and stiffness that worsens if she needs to sit during class for more than 30 minutes. On exam, she has synovitis in her bilateral wrists, right second MCP, left second MCP, and left second and third PIPs. Her feet are tender with MTP squeeze. So I wanted you to think about how would you describe this patient to your attending when you're precepting? What is your assessment or what is your one-liner? And this is extremely important because with your assessment, this is how we can categorize our differential. So hopefully you can take a moment and think about your one-liner, and it might sound something like this. A 21-year-old woman presents with subacute inflammatory symmetric polyarthritis. And we're going to just break down this sentence so you can really have a format when talking about patients with arthritis. So here, as always, we've learned this since medical school, you need to include the epidemiology. So the age and gender of the patient. And then it's very important to also not forget the time course. So is it acute, as is it hours to days? Is it subacute, days to weeks, or a chronic months to years issue? And then the most important word, which I bolded, underlined, you want to know, is it inflammatory or non-inflammatory? Next, I'm just going to skip over the pattern for a second and talk about the next really important adjective is to describe the number of joints involved. And we're going to come to this. And then again, symmetric, asymmetric, it's important to let us know the pattern. So hopefully, this is just a representative assessment, but hopefully yours sounded somewhat like this. It can certainly have more words or less words, but the ones in blue are really important to include. Okay, so when we're talking about the number of joints, I have a feeling you all know this already, but just to review, a monoarticular arthritis is one joint. And for inflammatory monoarticular arthritis, I've included a couple examples. It's not completely inclusive, but you just want to have some representative diseases for each category. So we tend to think about infections such as the septic arthritis for a monoarticular arthritis. We tend to also include crystal disease, so gout or CPPD, if a patient has a mono-inflammatory arthritis. Oligo is 2 to 4 joints, and this would include the spondyloarthritis, such as psoriatic arthritis, reactive arthritis, IBD-associated arthritis, and AS. And then a polyarthritis is 5 or more joints, and there's quite an exhaustive list. This is just a couple. RA and lupus tend to often make the top 2, but you can certainly include systemic vasculitis, systemic sclerosis, MCTD, dermatomyositis, polymyositis, infection as well. You can certainly have a polyarthritis that's caused by infections such as a bacterial endocarditis or a viral arthritis. Okay, so after the number of joints, you need to think about the distribution of joints. So we have a skeleton here, as well as a couple of hands. So you want to think about, are they large joints? Is it symmetric, asymmetric, axial versus peripheral? And just to really hone in on this, we're going to talk about the size. So small joints include the DIPs, PIPs, MCPs, and MTPs. Medium joints such as the wrists, elbows, and ankles. And then large joints would be knees and shoulders. Next, in terms of the pattern, you want to think about symmetric versus asymmetric. So is there a correspondence in joint size and arrangement on opposite sides of the body? Here in this first picture, we have a representation of RA, which is symmetric. It's affecting the MCPs, PIPs, MCPs, and other joints in a very symmetric pattern. The next picture, I should say, is psoriatic arthritis. And you can see here that the PIPs, DIPs, and so on are affected asymmetrically. Similarly, in the next picture, we have a patient representing, a picture representing ankylosing spondylitis. And again, it's asymmetric. And finally, this last picture is of non-inflammatory osteoarthritis, which can occur in a symmetric or asymmetric pattern. And finally, in terms of the distribution, we're going to talk about axial versus peripheral arthritis. Now, when we're talking about axial arthritis, we're really including the back, sacroiliac joints, hips, and shoulders. And you can see here, outlined in purple, what's considered axial. Often ankylosing spondylitis, more so than psoriatic arthritis, reactive arthritis, and IBD would be axial arthritis. And then thinking about peripheral arthritis here, we think about, this often will affect small to medium-sized joints, and psoriatic arthritis, reactive arthritis, and IBD have more of a peripheral distribution, although can be both peripheral and axial. And we tend to think of these diseases as being an oligoarthritis, so that's 2 to 4 joints, asymmetric, and affecting the lower extremity more so than the upper extremity. Okay, so that brings us to our final objective, and that's really thinking about studies. And I realize it just showed you the answer, but I'll go ahead and just read the question anyway. And so this is a 21-year-old woman with subacute inflammatory symmetric polyarthritis of the hands who comes into your clinic. And I apologize because you all can see the answer, but the first supposed answer would be you want to order CBC with DIF, a Chem7, LFTs, a SED rate, CRP, ANA, and ANA subserologies, which would be antibodies to double-stranded DNA, SSA, SSB, Smith, RNP, SCL70, which you would also get C3, C4, or rheumatoid factor, anti-CCP antibody, ANCA, anti-PR3, anti-MPO, bilateral hand x-rays. The second choice would be most of that. So again, the CBC with DIF, Chem7, SED rate, CRP, ANA subserologies, rheumatoid factor, anti-CCP, and bilateral wrist and hand x-rays. The third choice was CBC with DIF, Chem7, LFTs, SED rates, CRP, ANA subserologies, RF, anti-CCP, bilateral hand and foot x-rays. And then the final correct answer is CBC with diff, Chem7, LFTs, SED rates, CRP, ANA, rheumatoid factor, anti-CCP, and bilateral hand and foot x-rays. So when you're thinking about this, you have a 21-year-old woman with a subacute inflammatory symmetric polyarthritis. You're going to go back and think about that differential, and you really realize that RA and lupus are at the top of your differential. And instead of ordering all these tests, ANCAs and the complements and the subserologies, and they just differ a little bit here. You still have, all these subserologies. You just want to start with the basics, and you really want to use data for a hypothesis-driven selection of labs and studies. You want to avoid, oftentimes you'll hear this rheumatology gropogram of labs, and you want to just avoid the shotgun approach to ordering labs. Approximately 1 in 10 lab tests are a false positive. So it can really lead to unnecessary follow-up tests. It can lead to unnecessary patient worries and increased medical costs if you order a lot of lab tests that are unnecessary. And the ACR actually a few years ago worked on this campaign called the Choose Wisely campaign. And they really came up with a list to think about what tests should be performed in a hypothesis-driven, smart way so that we're not wasting resources. And they came up with some recommendations. And I think a really important recommendation is they recommend not test ANA subserologies without a positive ANA. So, antibodies to double-stranded DNA, Smith, RMP, SSA, SSB, SCL70, and centromere are negative if the ANA is negative. So you don't need to order these tests without waiting for the ANA to result first. Now, there are a few exceptions. One exception is an anti-Jo1 and an anti-SSA. And the anti-Jo1 can be positive in some forms of myositis when the ANA is negative. So an ANA is a nuclear antibody where the anti-Jo1 is cytoplasmic. So sometimes, even if an ANA is negative and you're still worried about a dermatomyositis or an anti-synthetase syndrome, you would order an anti-Jo1. And occasionally, an anti-SSA can be positive in the setting of a negative ANA. So if you're really concerned about lupus or Sjogren's and the patient has a negative ANA, then you sometimes might order an anti-SSA. However, for the vast majority, you want to order an ANA, wait for it to result, and then if it's positive, send the subserologies. Occasionally, when you have a patient in the hospital who's very ill, you would order an ANA and you may not want to wait for the result. And you may order these subserologies if a patient's critically ill and you don't have time to wait. But again, those are some exceptions. And I think we can really see this proliferation of broad rheumatology panels as a dramatic example of non-directed testing. And I would encourage you all to just be thoughtful about which tests you're going to order. Along those lines, another recommendation from the Choose Wisely series was to not order serial tests for ANAs, rheumatoid factors, anti-CCPs as a biomarker to follow disease activity in lupus and RA. So in the vast majority of cases, if an ANA is positive or the rheumatoid factor anti-CCP is positive, that's it. You don't need to keep checking. And occasionally, if there's a negative test and you think a patient has disease, you might repeat it in a few months to see if they've converted. Having said that, the ANA, the rheumatoid factor, the anti-CCP, once they're positive, you don't need to repeat them. Similarly, they made the recommendation to not test for Lyme disease as a cause of musculoskeletal symptoms without exposure and without an exposure history and concordant physical exam findings. Another test to avoid is to not perform MRI of joints to monitor inflammatory arthritis. So we have very good measures of disease activity with our history exam, and you can certainly check biomarkers like a SED rate or CRP, but you don't need to perform expensive MRIs in patients with inflammatory arthritis to monitor disease. Even X-rays, although they're not, it takes time for changes to develop on X-rays. You can certainly use X-rays over years to see if there's any new or worsening damage. And finally, to not repeat DEXA scans more often than 2 years. So the optimal interval for repeating DEXA scans is uncertain, but because bone density over short intervals doesn't change that much, it's unnecessary to order these tests more than every 2 years. All right, so thank you. That really concludes my lecture on the approach to the patient with rheumatic disease, but I made sure to leave plenty of time for questions, and I think I'm going to stop sharing my screen. And Nathan, I believe you've been moderating the chat a bit.
Yeah, wonderful. Thanks so much, Dr. Margaretten, for that great talk. There was a question that came up when you were reviewing the patient with subacute polyinflammatory arthritis and the laboratory workup, and the question was about the role for thyroid function tests.
Yes, I think it's very helpful to test for thyroid function. And if I'm correct, the question was about what were the most important tests, or was it the most recent poll question?
I'm not sure.
I would say yes, it's important to test for thyroid function, but if it was the young woman with polyarthritis, I would say it's not an absolute to, the list I gave, but it's just to guide a very systematic approach to ordering lab tests. So certainly if you're concerned about hypo or hypothyroidism as the cause of joint pain, it's very reasonable to include thyroid function studies in your initial approach.
Great, and there's actually another question that just came up in the chat that is about someone who is seronegative, but in whom you're really concerned about either a connective tissue disease or sort of unexplained inflammatory arthritis. Do you think about retesting serologies? And what is the sort of time interval you would allow?
Yeah, that's a great question, and that does come up, and I sort of try to make that caveat that yes, and so when the point of not repeating the ANA and the RF and CCP we're really when those tests are positive and you're not using them as biomarkers to follow disease activity. Certainly we have patients who the history and the exam is so compelling for inflammatory arthritis. The labs are not positive, but you are still concerned. So I usually perhaps 6 months later would repeat those tests. It kind of depends on how symptoms of the patient. And honestly, we continue to follow those patients sometimes because we have such a high suspicion, or we think that they may have, they may be seronegative RA. We follow those patients and we may treat those patients, and we would, I would recheck perhaps once, down the road, 6 months, a year later. Typically those antibodies, if they're positive, they're gonna precede, as we know that they actually precede disease often up to 10 years. So I do check maybe once more, but after that I kind of stop.
Wonderful. And if there's any other questions, folks can put them in the Q&A. Otherwise, I do think we have a brief poll that we'll complete before our next speaker. poll is up. And I'll just thank Dr. Margaretten again for a wonderful talk, and hand things over to Dr. Brasington, who is going to introduce our next speaker, Dr. Liew.
Thank you. And I'm going to thank Nathan and the wonderful ACR for inviting me to speak.
Dr. Brasington, you're more than welcome to start with the intro.
Okay, great. Well, good morning, everybody. My name is Rick Brasington. I'm coming to you live from St. Louis, Missouri. I am Emeritus Professor of Medicine at Washington University School of Medicine. I was Program Director there for 23 years and briefly overlapped with my distinguished protege, Dr. Lisa Zicker. I'm very happy today to introduce Dr. Jean Liew, who did her fellowship at the University of Washington. She is now an assistant professor of medicine in the rheumatology section at Boston University. And she does clinical research on osteoarthritis of the knee, which I find very interesting because that's what I have, and axial spondyloarthropathy. She serves on the COVID-19 Global Rheumatology Alliance Committee and is in fact on the steering committee. So with that, I'm very happy to introduce Dr. Liew.
All right, thank you. Just trying to make sure my slides go. So we're going to talk about OA in this next section. We're starting a little bit early, but hoping that everyone who is joining is already here. So I have no disclosures. And in this talk, we're going to go through a series of cases, and we're going to talk about how to approach these patient cases, how to explain the evidence, how to manage OA, and I hope that everyone gets something out of this that they haven't thought of before. So this is our first case. This is a 65-year-old woman who's presenting to established care for her knee pain. So she tells you that the pain is affecting both knees, the left side worse than the right. It's been getting worse over the past couple of years. The pain's worse when she's going up and down the stairs. She has a sensation of cracking in her knees, but she hasn't noticed any swelling. So as she's talking to you, she's asking, what are her risk factors for OA? What's actually causing my pain? So let's try to get some background for how to answer this. So just to bring everyone on the same page, the OA affects about 32 million US adults. It's a leading cause of disability, according to the Global Burden of Diseases study. And the rising number of total knee replacements performed every year is a reflection of its healthcare burden, as well as the inadequate therapies that are currently available that could prevent disease progression. Because currently, therapies can target symptom control, but none actually modify disease, meaning none prevent disease progression. So I hope by the end of this talk, we can learn something about OA beyond the feeling that OA treatment, it might be futile or might not be of interest to us as rheumatologists. So to start answering the patient's question, let's look at risk factors for OA, which can be broken down into modifiable and non-modifiable risk factors. And then these risk factors can also be broken down into those that lead to the joint being susceptible to OA, and factors that lead to the individual who is then said to be predisposed. So modifiable local factors that lead to a susceptible joint include muscle strength, particularly in the quads and hamstrings, or rather I should say muscle weakness there, physical inactivity, occupational associations, prior joint injuries, such as ACL injuries and meniscus injuries, as well as joint malalignment and the leg length inequality. So individuals could also be predisposed to getting OA due to modifiable factors, such as obesity, diet, as well as non-modifiable factors, such as older age, sex, female sex particularly, and some genetic considerations. So the prevalence of OA is rising, constant with the aging population and increasing rates of obesity. And this graph shows the global prevalence rate of OA per 100,000 individuals by age and sex. And you've got the age categories along the x-axis, and the red bars are for females, blue bars are for males, and you see that the females are overtaking the males in these age categories. And the relationship between aging and OA is complex, as well as the intersection between age and sex as well. And then we also know that people with OA are more likely to have other comorbidities. There's this high cardiovascular disease burden in OA specifically that is due in part to shared comorbidities and risk factors. So there's been a meta-analysis that demonstrated that people with OA have a high risk for cardiovascular related death, as well as all-cause death. And this is thought to be explained partly by physical inactivity due to the disability that happens from progression of OA. So what about the patient's question about what's causing her knee pain? So that's a little bit harder to answer, but we need to back up a little bit in how we talk about OA. So you might hear people talking about bone on bone, wear and tear, but we need to think about OA as a disorder of the whole joint, not just of the cartilage. It's total joint failure. It's not just wear and tear. So this is a really nice figure because it's got the normal on one side and then it's got an advanced OA knee on the other side. So you can have muscle weakness, as I said before, and this can lead to changes in the tendons and ligaments, the ability of the whole unit to function. The synovium can become inflamed and release cytokines and other factors that promote further inflammation, as well as breakdown of collagen, cartilage. You'll see cartilage destruction, as well as meniscal degeneration, and then you'll see new bone formation in the form of osteophytes. So all of this is going on in the joint. And then pain is the primary symptom of OA. It's the main contributor to functional limitations and disability. It's why people come to seek care. It's why people might come to see you. In the early stages of disease, the pain is primarily activity related. So recall in this case, the patient's having pain when she's going up and down the stairs, but not all the time. Later on, the pain can become constant. It can happen at rest, even at night. And this pain, constant pain, can also be punctuated by these episodes where the pain is worse and unpredictable. So what is actually going on with the pain pathogenesis? So this is another nice diagram that I'll try to simplify. So under normal circumstances, pain is a warning signal. So like you're touching a hot stove, you're getting pricked by a needle, pain's being protective, telling you to get away from that knock stem. But chronic pain, like in OA, is maladaptive because there's not really a knock stem going on. So early in OA, you've got nociceptive pain that's coming from the rich innervation in the joint. But later in the course, people can develop pain sensitization. So you have changes in the peripheral and central nervous system that are not actually due to damage in the nerves. And this can be quite hard to target with treatment. So back to your case. So you're reviewing with your patient how she has been managing her knee pain before she's seen you. So she says, tried Tylenol, I've tried ibuprofen, naproxen over the counter, I've tried a bunch of topicals, and each one of these, as you get the history, have helped only a little bit. So there's been a nice network meta-analysis looking at acetaminophen and various NSAIDs. So acetaminophen is no longer recommended as monotherapy. It used to be recommended as a first-line therapy, but we now know that it's a pretty weak analgesic. It's got a very small effect size in this meta-analysis, meaning that the benefit it has on pain relief is very small. For oral NSAIDs, they have a small to moderate effect size, and there's no one NSAID that is like definitely better than the other ones. So if you can make your recommendation based on what's helped them in the past, but in people with OA who tend to be older, you have to be cognizant of the safety of NSAIDs in terms of GI, renal, cardiovascular safety, and counsel people on adverse effects. But despite this, so acetaminophen is still conditionally recommended by the ACR for OA, and oral NSAIDs are strongly recommended. And we're going to see a lot of these green boxes. There are also going to be red boxes, and these are from the latest guidelines from the ACR for OA. Okay, so topicals. Lidocaine patch. This has actually been studied versus celecoxib, and they saw that there is actually no difference in pain benefit between the two in knee OA. So that is an option. You've got capsaicin, which comes from chili peppers, with a picture to remind you up top. It targets these channels that cause release of substance P from C nerve fibers, and this leads to reduced sensitivity to pain. And there's actually been a meta-analysis of studies showing that capsaicin has a pain benefit over a placebo. So this is another option. And then topical NSAIDs, there has been a meta-analysis that actually says that diclofenac patch works best on pain function, but I think the thing that we typically recommend is diclofenac gel, like Voltaren, that you can get over the counter now. So capsaicin, strongly recommended. Topical NSAID, strongly recommended by the ACR. Okay, so besides discussing pharmacologic therapy or surgery with the patient, what are important things to also talk with her about? So not also as in on the side, but like important first-line recommendations. So we need to remember the importance of patient education and self-management, and all of this leading to self-efficacy. So this is an ongoing process as you're counseling them, as you're following them. You need to tailor this to the individual, and you're focusing on behavioral and lifestyle modifications, not just on referrals and pills that they could take or interventions that they could get. So before we can really do this, you need to have a better understanding what the patient's options are for self-management. And besides Tylenol, NSAIDs, and the topicals we discussed, what else can they do outside of clinic? So first, some definitions between physical activity and exercise. Physical activity is this broader term that includes exercise, but it's also inclusive of things like walking your dog or gardening, things like that. Exercise is more planned, structured, purposeful. It's an activity meant to improve your physical functioning. So there are guidelines for adults. These are general, not just specific to OA, but they recommend that you get 150 minutes per week of moderate to vigorous physical activity. So this could be chunked out to 3 to 5 times a week of 30 to 60-minute intervals of whatever physical activity you're interested in. But we also know that in studies, a majority of people with OA don't meet these guidelines. And the main reason is that they're concerned about worsening OA, that any kind of physical activity or exercise might worsen their OA in terms of pain, worsen the structural damage. And we actually have no evidence that this is true. We've actually got studies that have debunked this. So do not let this myth keep people from wanting to do physical activity. Reassure them. So what are exercise types? I'm just going to say overall that traditional modes of exercise, including all of these on the slide, are effective in improving subjective and objective physical function in OA. So strength training to target muscle weakness. You've got high resistance things like weights, machines. You've got stairs, rowing. Aerobic training is low impact, high repetition, helps with cardiopulmonary benefits. So this can include cycling, elliptical, things that are low impact, swimming, if someone is more interested in that versus land-based things. You've also got flexibility, range of motion exercises. And then the final category is neuromuscular training, which improves joint proprioception, balance, stability, because a lot of people will say that they feel unstable on their knees, they feel like they're buckling. And that is going to be helped by doing strength training to improve their muscle strength, but also this neuromuscular training. And then many recent studies have also investigated Tai Chi and yoga in the OA, and they've all demonstrated, or most of them have demonstrated, a beneficial impact on pain symptoms. So we do have evidence here, and we do have actual pilot trials and randomized trials to give us information. So for Tai Chi, we have these RCTs where Tai Chi was compared to manual or exercise related PT, and in both groups they had significant improvements in pain and function at 12 weeks, and some studies have also shown that this is maintained beyond that. So meaning Tai Chi would be comparable to doing an exercise program that's supervised. And then there's been this yoga pilot study looking at yoga versus strengthening and aerobic exercise. And in that study, which is quite small, the yoga group actually had greater improvements in pain after doing the yoga for 8 weeks. So these are additional recommendations that you could offer your patients. So patients do better with specific recommendations and prescriptions. So instead of saying you need to exercise or you should exercise, try to figure out how to give them specific recommendations. So there's no single type of exercise that's been proven to be most beneficial. And you have your selection here. You could do at home, supervise in a group, active or passive, land-based or aquatic. But out of these considerations, think about what is the frequency, what is the intensity that would work for this patient that they could do, and how can you progress this over time. So to improve adherence to exercise, you have to make some considerations, because when you present data saying in this study, it showed that people like you were able to improve their pain or function after doing exercise for X amount of time, you also have to recognize that that is in an ideal setting, but the patient in front of you is in the real world. So also these studies are following people for maybe 3 months, maybe up to a year, but what about long term? So to improve exercise adherence, you need to remember educating people about the benefits. So now that you have some idea of what the objective benefits are from these studies, you can think of how to convey that to your patients. You develop a plan with them, engage in shared decision making, and also consider starting slowly and working their way up, because you don't want them to think, okay, I need to get some running shoes and go jogging, or I need to go to the gym and do some heavy workouts. That's not going to work for a lot of people. You need to let people know that doing something light that they can fit into their schedule to start with is also appropriate. So if they can walk half a mile around like their neighborhood or in the park, that is a good start for a lot of people. And then consider sending them to get expert instruction like PT, doing an supervised exercise program so they're not making it up from the start. And then encourage self-efficacy. So set goals with them, give them positive reinforcement when you see them again. And also if they're more tech savvy, you can talk to them about self-monitoring devices like a Fitbit, a smartwatch, so that they have goals on how many steps they would take per day. So besides exercise, you can also consider weight loss. Exercise and weight loss show the greatest clinical effect for improving pain and functional outcomes together. And weight loss is recommended in all clinical guidelines for anyone who's above a healthy weight. So for weight loss, diet, and exercise, you can take a team approach with nutritional counseling, an exercise program, and counseling the patient on behavioral strategies all together. There's been a trial of overweight and obese adults with NEOA that showed diet and exercise, or diet alone, had a greater impact on weight loss than just exercise. So that's another consideration. And then in people who would meet indications for bariatric surgery, that is yet another consideration. So back to the case. So the patient is now here for follow-up. She's tried to incorporate more exercise into her schedule, and she's trying to increase her time spent walking. She's using a smartwatch as encouragement. And now she's asking whether supplements would be additionally helpful in addition to whatever she's doing now. So what's the data for this? So glucosamine and chondroitin, something you can get over the counter anywhere. You can buy large bottles of it at a Costco. The mechanism of action is felt that these glycosaminoglycans that are part of the healthy cartilage, if you take them in pill form, that they would reconstitute or supplement or replete the healthy function of the cartilage. Although I think it's still unclear whether oral intake of these supplements would actually lead to enough incorporation into the joint for this to actually happen. So there's been an RCT, it's quite old at this point, from 2006, it's called GATE, and they showed that there was no benefit of glucosamine, chondroitin, either alone or in combination when compared with placebo. There's also been several meta-analyses, and they've all highlighted concerns of publication bias because they've seen that when you just restrict the results to studies that were sponsored by industry, there seemed to be a benefit of using glucosamine and chondroitin, but when you try to account for that, there was no benefit. So the ACR strongly recommends against these as an option for knee OA. So what about other supplements? Vitamin D, fish oil, again, things you can get in large bottles at your Walgreens, your CVS, whatever, over the counter. Vitamin D, RCTs in multiple were all negative. So even though it may benefit bone health, it doesn't demonstrate a substantial impact on pain and function in OA. And then in fish oil, there was one RCT where they looked at a high dose fish oil, the high dose being the one that was supposed to have these anti-inflammatory properties, versus a low dose fish oil that was felt to not have the anti-inflammatory properties. And interestingly, the results are flipped, with the one that was not supposed to benefit OA at all having the greater benefit in pain and function. And they haven't really been able to explain that, at least not in the publication of that trial. So the ACR conditionally recommends against vitamin D and conditionally recommends it against fish oil. So if someone feels that it's helpful, there's not really enough there to say that it's harmful for them to take it. So it's not a strong recommendation against at this point. Okay, same patient, back to the case. So she returns a few years later. She's had a couple of trials of PT, moderate benefit each time. And she says that her exercise routine has fallen off a little bit. She now notes that she's having swelling in her knees. She's having pain with more activities. It's not just with stairs now. And in this clinic visit, you discuss going back to PT again because she's had some benefit with it. And she's asking about knee injections. So intra-articular steroids, what's the evidence? So we've got this Cochrane review from 2015, so not too old. It's looking at RCTs where they compared steroid injections either versus sham or no treatment. And overall, it's going to say short-term benefits, right? So you have a moderate effect on pain a week, 2 weeks out, smaller moderate effect about a month, month and a half after that, smaller effect after that, and no clear effect at 26 weeks. So you'll hear a lot of patients who said, yeah, that last injection really helped for like 2 weeks or a month, and then it fell off. Some people do have longer term benefit up to several months or even a year, but I think if you look at it on a population average, it's going to be a short-term benefit and not really a long-term benefit per injection. There has been a concern about the risk of worsening cartilage loss in the knee after these injections, and this really stems from this 2017 RCT of intra-articular triamcinolone versus saline for knee OA. They saw a non-significant greater risk of cartilage loss at 2 years in the steroid group versus the saline control group. But there have been a lot of comments about what's the clinical significance of this. So the between group difference really amounted to a very small, like tiny change on imaging in terms of the cartilage thickness. So it's still unclear if this is really enough of a harm to say we would not recommend doing joint injections of steroids. So steroid injections are still conditionally recommended by the ACR. What about other types of injections? So viscosupplementation refers to things like hyaluronic acid. It's polysaccharide. It's decreased in OA joints. So the thought is, if you're adding more of this into the joint, it can help with joint lubrication. In the picture of the rooster is because this comes from coxcombs, is how it's manufactured. Summary of evidence in meta-analyses: either no effect or only small effects in pain, and no benefit on function. So ACR conditionally recommends against physical supplementation like hyaluronic acid in the OA. And in terms of safety, costs, those are also considerations. So cost, it's going to be more costly than the steroid injection. And then safety-wise, some people may have a sensitivity reaction to this injection where their knee becomes really swollen and painful afterwards. So that's something you need to counsel them on if you are going to do this. Back to the PT part. So we are talking about maybe doing an injection with this patient, but also recommending that she go back to PT, and she can do both of these together. And these are often things that you counsel together in the same visit. So PT continues to be woefully underutilized, even though, as I said earlier, it's a first-line treatment recommendation for OA. We've got one study in the US looking at people with knee OA, and about half reported they had utilized PT in any fashion. And they found that female sex, higher education, those are related to, they were associated with higher odds of having used PT before. And this is also reflected on this in a study from Taiwan, where people had, again, a dismal proportion, very small proportion of people would use any PT, like even one session within a year of their OA diagnosis. And they found that male sex, older age, lower income were less likely to get PT. So we need to have consistent messaging about the utility of PT, and we need to keep thinking about when it's appropriate to refer, to recommend. We also, of course, have to think about what are the barriers to PT. So even if you do refer them or someone else refers them, they may not be able to go. So patient level barriers might be, patient may not understand why they're getting referred to PT or what's the use of it. They might think, well, if I take pills or I get injections, it's going to be a lot better than going to PT. They might have barriers to access some care. So there may not be any place that takes their insurance that's local to them that they would be able to go to 2 or 3 times a week. Their insurance might also just be a barrier in them getting affordable care through PT. And then on the provider level, the provider might not understand the efficacy, and that can affect the way and bias the way that they make the recommendation for the patient to go to PT. They might be under time pressures and not recommend it and not take the time to thoroughly educate the patient, and just other biases about referring the patient. So when considering PT, not only do you think about the dose, the prescription for exercise, you also have to think about what are the barriers on the patient level and the provider level being you as well, that might limit someone being able to actually engage. Okay, so that's the first case. Next case. So now you have a 60-year-old man. He's had a diagnosis of knee OA for several years. And then more recently, he has stopped having response to a bunch of therapies, topicals, oral, steroid injections, physical therapy. He's got this severe pain that affects him throughout the day, also affects him at night, wakes him up. And he comes to you because someone else has ordered a knee MRI. It shows a meniscal tear as well as these other features, abnormalities on the MRI that suggest he has moderate to severe radiographic OA. So what about arthroscopic procedures? So not a knee replacement, but other types of knee surgery. Are they helpful here, or are they going to be helpful for this patient, particularly if he has this meniscal lesion on the MRI? So meniscal lesions on MRI in the knee are common in people with OA. They're also pretty common in people who don't have clinical OA. So that alone is not an indication for someone to undergo an arthroscopic procedure. And then there's actually an RCT, or several RCTs that are listed at the bottom of the slide that show that arthroscopic partial meniscectomies do not improve pain or function over comparators such as usual care, physical therapy, or sham surgery. So this is not recommended, although there have been studies recently that show that people are still getting meniscus surgeries routinely done prior to getting a total knee replacement. So that means these people do end up going on to needing the knee replacement anyway, but they had the meniscus surgery in some time prior to that. So joint replacements. So in general, knee and hip arthroplasties, which are joint replacements, are efficacious for people with severe OA who have symptoms that are hard to manage, like this patient example, where he's tried a bunch of different things and he's still having severe pain. So it's indicated in these types of patients. And the level of evidence is that we actually have an RCT looking at knee replacement versus multimodal therapy alone. And the knee replacement group had improvement of pain and function over the other group. The knee replacement group in that RCT did have more serious side effects because they got a surgery. So that's to be expected. But you also have to think about the other multimodal therapy, including physical therapy after knee replacement. And it's not just a surgery alone that would benefit pain and function optimally. But the last caveat, though, is there are 20 to 30% of people who undergo this knee replacement and they still have persistent pain. So we're still studying what are the factors and what are the possible interventions we can do to prevent this or mitigate this. But this is something to think about, that you shouldn't present a joint replacement as the silver bullet. It's going to make everything go back to the way it was, because it may not, they may not have well-controlled pain even after the surgery. Okay, so this is the last case. This is not knee OA. This is a third patient who's coming for hand pain and swelling. So this is a hand OA case. So you know that she's got a family history of arthritis affecting the hands. It's a deforming type of arthritis. She says that her mom, her grandmother had it when they were older. And then you see that she has large nodules in her DIP. So this is clearly hand OA. She comes to you after her PCP gave her prednisone 10 milligrams daily for a week with some benefit, but the pains returned. And the referral request actually says in the chart, would this patient benefit from getting a DMARD since she had response to prednisone? So inflammation in OA, this is complex. We're definitely not going to talk about the pathogenesis of inflammation in OA. I will just say that levels of many pro-inflammatory cytokines and chemokines have been elevated in synovial fluid of people of OA compared to people who didn't have OA. And studies of this ilk have suggested that targeting some of these cytokines or pathways could be beneficial in pain, symptoms, and structural progression in OA. So what about the evidence? What trials have been done, and what does the ACR recommend? So this is in hand OA again. So with hydroxychloroquine, pre-RCTs, small to moderate size of sample size, and these were all negative. So they all looked at pain at 3 months up to 12 months and did not find any benefit with hydroxychloroquine. Colchicine, there was a small RCT, looked at pain in 3 months versus placebo. This was negative. And then this methotrexate trial of erosive hand OA, also small, pain at 3 months, also negative. So ACR recommendations are strongly against, strongly against, strongly against using all of these in routine standard practice for the treatment of hand OA as well as knee OA. TNF inhibitors. So these have been studied as well. There are these 3 trials of small numbers of hand OA. They looked at etanercept, adalimumab, which are Enbrel and Humira respectively, if you like the brand names, compared to placebo. And unsurprisingly, these are also negative. So the ACR strongly recommends against using TNF inhibitors for the treatment of hand OA as well as knee OA. And then finally, IL-1 inhibition. This is not hand OA, but this is knee OA. So you've got some slightly larger trials. You've got anakinra, which you might recognize, and as well as these two other agents that also target IL-1, but are not things that you have probably heard of. These are also negative. That's the theme of this part of the talk. And the ACR, again, strongly recommends against using IL-1 inhibitors, these biologics, in the treatment of knee OA as well as hand OA. But the story doesn't really, it's not over. So there was this large trial called CONTOS, and it was not meant to study OA in any sort, but the original trial was looking at people with cardiovascular disease and elevated high sensitivity CRP, and they're looking at a major adverse cardiovascular event as an outcome. In canakinumab, this IL-1 inhibitor versus placebo, in this trial, they did a post-hoc analysis looking at an outcome of total hip or knee replacements. And they actually saw that across all the doses of canakinumab that they used, that this was statistically significant protective effect of benefit. So people who got IL-1 inhibition had a lower risk of needing hip or knee replacements on follow-up in this really large study. So this is a finding that then supports this hypothesis that maybe in a subset of individuals with knee OA who might have high levels of inflammation, maybe directly targeting inflammation with a cytokine inhibitor like IL-1, like an IL-1 inhibitor might be helpful. So this also speaks to more work in phenotyping and subsetting people with different subsets of OA. But this is more in the research realm and is not something that we in standard practice currently do. So we're not giving people anakinra or canakinumab for their knee OA, but would be aware that these are trials that are being conceptualized at this point. So we are ending super early, and this is my last slide, but this is if you took a bunch of recommendations and guidelines for OA, you might end up with something like this. It's hardly confusing, but you can't really use this in the clinic with a patient. So you need to boil it down into something that you can think of in a simpler fashion. So it's not a treatment pyramid. There's nothing that comes out on top. You're doing all sorts of things at the same time in this multimodal approach. You're thinking about physical modalities like exercise, PT, pharmacologic approaches, including topicals, orals, injections, mind-body approaches, Tai Chi and yoga fall into that, and surgical approaches. And you're thinking about all of them, and you're educating patients on these options, and you're also educating them on self-management. What can they do in between clinic visits when they're at home that would help with the symptoms like pain and function that is related to their OA. So with that, thank you. And I am going to stop sharing and can take questions. Thanks.
Okay, so we have a couple of questions from the group. First, in the ICS versus sham, did both groups benefit from injections initially, or did neither?
I need to actually go back and reread that study, but this is the McAlinden 2017 paper. So I think let's all go back and reread that and look at the graph. I'm sorry that I can't answer that.
Okay, great.
On the fly. Okay,
I think you may have already answered this, but what is your input about using low-dose prednisone with inflammatory or erosive osteoarthritis of the hands?
So that's a really good question. So there was this HOPE trial that was conducted in Europe where they actually tried to phenotype more specifically these people with hand OA. They actually did ultrasound to enrich their trial for people who had an inflammatory erosive hand OA picture. And then they treated them with prednisolone 10 milligrams for some period of time. And they showed that there was benefit in that trial. The guidelines still do not make a recommendation for using prednisone or any oral steroid for hand OA, but given that trial evidence, in that specific phenotype of hand OA, it's a consideration if they've responded to steroids before. But of course, you need to, just like in the case of oral NSAIDs, think about and talk to the patient about what are the potential harms of having a lot of repeated doses of steroids.
Okay, excellent. So we also have a brief survey for you to look at and answer.
Oh, and I think someone else asked about central pain modulators like duloxetine. So duloxetine is also in the guidelines, and there have been in the past year, I believe, there are 2 trials that are, I think, conflicting in terms of whether duloxetine was beneficial in pain outcomes in OA. But this was back to talking about like pain sensitization and whether you can target those neurological processes. So duloxetine is a consideration. It's not a first-line consideration, but it's a consideration that's on the plate for someone who has more pain sensitization and like a fibromyalgia-like picture.
Okay, thank you. I'm sorry, I did not see that question on my screen. So now, if we could bring the survey back up. Janet, can you bring the survey back up?
Dr. Bracington, I did, and I got a large response. So
Okay. Yeah,
yes,
I took it
fine.
down so I could see Dr. Liew's face.
No, that's fine. Thank you.
Okay, so are we done for the morning?
We are.
Okay. Well, I'd like to thank everyone. I'd like to tell the fellows you're very lucky to have had an excellent lecture on osteoarthritis.